Good evening, everyone. I'm Michael Heppel, Associate Dean for Research Strategy and Outreach in the College of Education and Health Professions. And I'm excited to welcome you to our fall 2024 We Care Speaker Series. We launched this speaker series a year ago as part of our We Care strategic plan and its impactful research priority. Each semester, we invite faculty to nominate prominent scholars who we can learn from their expertise on important topics in education and health. And our faculty organizers this semester have expanded our vision from what the speaker series can be, from going from one speaker to two renowned scholars and organizing a panel with national experts and local leaders. Before I pass the microphone to our faculty organizers, I want to thank a few people who made tonight's events happen. First, Dean Kate Momiseshvili for envisioning the speaker series and providing the funding for it. Brittany Packard and Kate Bruska from the COEP Dean's Office, and Kristen Jett from HHPR, who handled tons of the organization that we needed to make tonight happen. Eric Starfield has helped make sure we have all the technology we need, and he's around here somewhere in case something goes awry. And our communications team of Shannon Maxim and Sean Romberg have helped us spread the word, and we'll make sure tonight's activities are well documented. But most importantly, I want to thank exercise science faculty members Aaron Howie Hickey and Nick Green for envisioning tonight's event and for all their hard work in making it happen. So I'm going to pass it off to Dr. Green.
Thank you, Dr. Bell. A couple words tied to the Research Center and essentially get out of the way, because Aaron and Kristen have done a wonderful job really setting tonight up. Relative to our Research Center, a couple of years ago, we did another event, and it appears we've been operating since about 1969, originally as a human performance lab. Anytime I step forward in this role, I have to take a moment to recognize some of the other people who preceded me in this role. Dr. Barry Brown, I believe, actually started this. Dr. Charles Riggs, of course, passed a couple of years ago. But we're fortunate in the room tonight to have Rhoda Breslow in the board, Matt Gannio somewhere, and Michelle Gray. And I feel extraordinarily honored when I get to step in front of you and follow in their footsteps, because they have helped us build something that is becoming more and more renowned. I'm just lucky to be in this position at this moment when we get to do some of these things. Relative to our research center, pulling a few pieces of data, and the growth has been outstanding in the time I've been here. Last year, if I counted correctly, when I did annual reports, about 45 peer-reviewed publications. A little more than 4 million in newly committed funding, over 6 million in funding that was ongoing. All of our standard metrics of research are absolutely outstanding. We've recently had students and faculty presenting all over the world: Stockholm, Limerick, Munich, and back here at home. And it is, I think, extraordinary to be able to watch this. I'm staring at my good friend Tyron Washington, who received his first NIH funding this summer. So that said, exercise science is an extraordinarily broad field, and that's one of my fun things about being the director, getting to try to find ways to promote all of the different work we have going on. From bench science that several of us are doing in muscle biology, to applied physiology and biomechanics, out into the communities. And I think some of that highlights and helps us bring to what we're here for tonight. So I really have to just stay in all of it, and I love getting to promote every one of you. And I think one of the best things tonight is to watch where Exercise is Medicine has gone from a national event to where it is with Aaron and Kristen here on our campus. I do want to recognize briefly while I'm on the stage, our speakers, our panel. We have three past presidents of the American College of Sports Medicine in front of this room. That is a rarity if we're not actually at the annual meeting to get that type of, well. Please, as we go through the night, join me in welcoming them. One of them is personally why I am an academic. So I have a little extra pride right there. All right, Aaron.
Yeah.
I would like to turn it over to you. You must get this really started.
Well, I'm not going to. Like both Dr. Hevel and Dr. Green said, thank you to We Care and especially to Dean Kate for supporting not just this event, but exercise as medicine as a whole since she's become dean. We really appreciate the support. So for those of you who are not aware, Exercise is Medicine is an international initiative. It was started to be debated 2006, 2007 with the American College of Sports Medicine. And it's really aimed at integrating exercise and healthcare together so that healthcare professionals are giving credit to physical activity, treating it as a vital sign where they both assess it and promote it. Exercise is Medicine on campus is a branch of Exercise is Medicine. It has over 200 campuses worldwide that participate. And it also aims to promote exercise as medicine among students, faculty, and staff on campus, again, through assessment and promotion. The University of Arkansas became a recognized exercise as medicine on campus in 2018. And most recently in 2024, we gained gold level status, which is the highest recognition that you can get from exercise medicine on campus, partially again in support with some of the support from Dean Kate. Dr. Green already mentioned how the American College of Sports Medicine is our kind of major national, international professional organization. And we're very lucky to have three of our past presidents here that are going to share some of the wisdom. So this brings us to our speakers for today. So our first two speakers, they're going to speak for about 30 minutes each. And then we're going to take a quick transition break. You can get up, stretch, get the wiggles out. And we're going to bring up our discussion panel. So if you do have any questions, hold them until we start our discussion panel. And also, I encourage you as you listen tonight, and especially the days after you've been inspired by these experts and practitioners in healthcare and recreation, to think about how you can really be part of the exercise as medicine movement. Because it's not just me and my research agenda, it's not just Kristen, it really is a campus and community-wide initiative. So whether it's for you personally, how you can become more active, or if you are involved in healthcare, or for students who might become healthcare professionals, really take what you listen to today and apply it to your work, whether it's teaching, your scholarship, or your family and the community as a whole. That's my challenge for y'all. I'm not from Connecticut. I say y'all now. All right, so with that, I'm going to introduce our first speaker. I was reviewing their CVs to pick out the stuff that I found most interesting, and it was really hard. But Dr. Barry Franklin, he is the Director of Preventive Cardiology and Cardiac Rehab at Corewell Health, which is at William Beaumont University Hospital in Michigan. He has over 500 peer-reviewed papers related to exercise physiology and cardiology. He also has a second career, which is pretty awesome, and recently is the author of GPS for Success, Behavioral Skills, Strategies, and Secrets of Superachievers. He has a whole bunch of different fellowships, including the American Heart Association, the American Society for Preventive Cardiology. He was the past president of ACSM from 1990 to 2000. And I really want to thank Dr. Franklin, especially here from the University of Arkansas, because him and his wife, Linda, sponsor a microgrant program through the Exercise as Medicine on Campus initiative. And we were one of the inaugural recipients of it, which really kicked off our exercise referral program here at the university. Thank you, Dr. Franklin. And with that, I will turn it over to you.
Good evening. It's truly an honor and pleasure to be here. Our special thanks to Doctors Nick Green and Aaron Howie and Kristen Jett for the invite and for the coordination of my entire visit. It's a particularly pleasurable visit. I'm really enjoying it. It's my first visit to your beautiful state, and I must admit I am singularly impressed with the campus and the people I've met. There's also another plus for me, and that is working with two dear friends and esteemed colleagues, Dr. Liz Joy and Larry Durstein. Thank you all for your warm and gracious hospitality. I have a formal mission. I've got 30 minutes to share with you what I've learned in the last 50 years. I started this field in the early 1970s, and for the last 50 years, I've been studying physical activity, cardiorespiratory fitness, their impact on health outcomes. My goal is to cover this today in 30 plus or minus 2 minutes, and we'll go through this topic fairly quickly. I always start with a preview, then the feature presentation. The preview is, what have I learned in 50 years? What's my most famous professional story? It happened about 5-6 years ago. I get an email from a colleague in India. It said, Dr. Franklin, I was so pleased to see your famous quote on our European Preventive Cardiology Conference bag. Congratulations. An ounce of prevention is worth a pound of cure. I'm old, but I'm not that old. Hell, that's not my quote, that's Benjamin Franklin. And what you may not know is he wasn't talking about health, he was talking about preventing fires. If you're looking for more information on this topic that I'll cover, we wrote a review in Mayo Clinic Proceedings last year with basically the same title. So if you're looking for additional information, I'm going to give you tonight a 30,000 foot overview. I'll cover 7 topics, so once I hit number 7, you'll know it's the last 8 or 9 minutes. Topic number 1, physical activity and fitness as modulators of mortality. I could cover a lot of studies, but I want to talk about the early studies that got my attention. Well, the first one by Hakim and colleagues, New England Journal of Medicine, 707 non-smoking retired men, 61 to 81 years of age. They looked at the distance walked of those individuals, 12-year follow-up, over 200 deaths. What did they find? The mortality rate among those men who walked less than a mile a day was nearly twice that of those who walked greater than 2 miles a day. The conclusion was regular walking associated with a lower overall mortality rate in older physically capable men. Whenever I give this talk, usually at the grand rounds, somebody will stand up and say, Sperry, show me the data. Here are the data. Like graphs. Hold on one second. The graph is missing, but we'll continue on. Reduced walking speed. I tell our fellows and residents, simply look at how fast your patient walks out of the office that day. It's probably the single best prognostic indicator. 2 landmark studies, Stanaway and Studensky, both in 2011. Basically, what these studies showed is if your patient walks out of the office less than 2 miles an hour, he walks out like this, he's probably heading in that direction. If, on the other hand, that patient walks out at 3 miles an hour, 75, 80-year-old guy, and he says, okay, bye, doc. Those people do very, very well, just how fast they walk on a day-to-day basis. In fact, these studies showed with 6-year follow-up, nobody who could walk at 3 miles an hour day-to-day on a regular basis passed away over that follow-up period. Why do I believe it's the case? If they're walking at 3 miles an hour, they're walking functionally at 3.3, 3.4, 3.5 METs, which means if I put them on a treadmill, they're going to be 5 METs, which gets them out of the least fit, the least active, the bottom 20%, the highest risk cohort. Let's move on now and talk about cardiorespiratory fitness. The late Dr. Stephen Blair, landmark study, Jim, in 1989. Here he looked at over 10,000 men, 3,000 women, 8-year follow-up. Looked at fitness, estimated, and mortality. What did he find? As I show you this graph, 3 things got my attention. Number 1, beyond 9-10 METs, mortality largely leveled off. That's completion of stage 3, the Bruce Treadmill protocol, 3.4 miles an hour, 14% grade. Secondly, as they went from less than 6 METs to 7 METs, there was a huge drop. Blair and colleagues concluded that higher levels of physical activity appeared to delay all-cause mortality secondary to reductions in cardiovascular disease and cancer. This second study got my attention, also published in JAMA in 1996. He looked at indices of fitness as well as other precursors for mortality. What did he find? Look at this graph. Let me ask you, what was the single best predictor of mortality? I like a little audience interaction. What was the best? No fitness. It beat cigarette smoking, high hypertension, high cholesterol, overweight, or obesity. In fact, this study concluded fit persons with any combination, smoking, elevated blood pressure, and elevated cholesterol, had lower adjusted death rates than low-fit persons with none of these characteristics. Wow. These studies were in some respects criticized because they said you can look at one data point, what's happened over all that period of time. In this study, Blair looked at 2 data points. Almost 10,000 men, 10-year follow-up period, evaluation 1, evaluation 2, 5 years later, then additional 5-year follow-up. What did he find? I'm not going to show you a complicated table. I took a complicated table that you can't even read. Here's the 3 take-home points. Number 1, unfit people at both evaluations had the highest death rate. Fit people at both evaluations had the lowest death rate. But people who were initially unfit, who became in the fit category, had an intermediate death rate, suggesting that improvement in fitness caused mortality. We oftentimes argue, is this association or causation? This is a piece of data that suggests causation. Each 1 minute increase in treadmill time, there was about an 8% decrease in the risk of mortality. And study after study after study, we show that as cardiorespiratory fitness increases, mortality decreases, and as cardiorespiratory fitness decreases, mortality increases. My good friend John Myers, this was the Veterans Administration study over 6,000 veterans, 6-year follow-up period. What did he, slides. Topic number 2, impact of physical activity and fitness on heart failure, survival, incidence, cancer, COVID-19, dementia, and stroke. What John Myers showed in that previous study, and I don't know why we're missing the slide, but what he basically showed is whether you're obese or diabetic, if you further divide people into fitness, those people who were low fit were 2 to 3 times more likely to die in follow-up. That's what that slide showed. Impact of physical activity and fitness on heart failure, survival, incidence, cancer, COVID-19, dementia, and stroke. It's an early study I looked at, looking at heart failure patients. These are people with bad hearts. And they're looking at them and trying to decide, does this patient need heart transplant? So what they did is looked at VO2 max, it's an index of fitness, and then looked at subsequent mortality over a 12-month period. They concluded cardiac transplantation can be safely deferred in ambulatory patients with severe LV dysfunction, with an exercise capacity greater than 14 ml per kg per minute, which is 4 METs. Patients with an aerobic capacity greater than 18, 5.1 METs, demonstrated 100% survival. Here are the data. Look at this. These are all heart failure patients. If they had above 18 ml per kg per minute, 5.1 METs, 100% survival. This was one of the early studies that made me aware of the magic of 5 METs. You're over 5 METs, you tend to do very, very well. In fact, when I saw these data, a light bulb went on in my head. This next study was a heart failure study that I was involved in. We looked at 20,000 heart failure patients. We followed them over a 13.9-year period. And basically, what we did is divide them into normal weight, overweight, and obese, and further divided them into high fit, moderate fit, low fit, and least fit. What did we see? Look at these data. Basically, what we found is regardless of BMI, those individuals who had the least fitness were 2.5 to 3.5 times more likely to develop heart failure in later years. Take-home message, regardless of BMI, individuals with low cardiorespiratory fitness in their middle age are more likely to develop heart failure in their later years. When it comes to heart failure, it's better to be overweight, obese, and fit than normal weight and unfit. Let's now look at modulators of cancer incidence. Two major studies that got my attention. In this analysis of 1.4 million individuals, higher levels of leisure time physical activity associated with a lower risk of 13 of 26 cancers evaluated. U.S. Department of Health, Human Services, and ACSM came to similar conclusions that there's strong evidence to support the benefits of regular physical activity for the prevention of those types of cancers. Another systematic review by Schmidt and colleagues published in 2015, systematic review of over 70,000 individuals with cancer, over 2,000 deaths in the follow-up. Individuals, listen to this, diagnosed with cancer who had the highest levels of cardiorespiratory fitness had nearly a 50% reduced risk of cancer mortality compared with the lowest cardiorespiratory fitness. They concluded regular, moderate to vigorous physical activity and increased fitness are associated with reduced cancer risk and better survival outcomes among individuals diagnosed with cancer. It was a great study done by dear friend and colleague, Bob Salas. At Kaiser Permanente, they have patients self-report physical activity levels. These were 48,000 patients at Kaiser Permanente who were identified with a COVID diagnosis, all had at least 3 self-reported physical activity assessments in the previous 2 years, classified into 3 categories: consistently inactive, some activity, and consistently exceeding physical activity guidelines. What did they find? Wow. Those who were consistently inactive had the highest risk of hospitalization for COVID, odds ratio 2.26, admission to the intensive care unit 1.73, or death 2.49. Those who had some activity had lower odds for adverse events, and those meeting or exceeding guidelines had the lowest rates, complications from COVID. They concluded that habitual physical activity to lower COVID illness severity should be promoted widely by the medical community. Topic number 3 of the 7, impact of chronic physical activity and hospitalization for acute coronary syndrome. Role of exercise preconditioning. This is a study I read back in 2008. This is what I do on a day-to-day basis. These were over 2,000 patients in Greece who were hospitalized with chest pain. They wanted to look at what's the effect of pre-admission physical activity status on in-hospital mortality and 1 month post-discharge cardiovascular health outcomes. What they find was astounding. Physically active patients demonstrated lower odds of in-hospital mortality and lower odds for recurrent cardiovascular events in the first 30 days of hospital discharge. This phenomenon, many medical professionals have no idea what it is. This phenomenon shows that exercise provides immediate cardiovascular protection. John Quindry has done more than anybody in the world in running rats, running animals, ligating a coronary artery, and looking what happens conditioned versus sedentary animals. He's found, and more recent studies have found, that exercise preconditions the heart. What does that mean? This occurs after just 1 to 3 sessions. So it means if I have patients exercising, they start a cardiac rehab program this week. They exercise 3 times. And God forbid, one of those patients has a heart attack next week. These data suggest that that heart attack will be less severe, less damaged because of those 3 exercise sessions. The implication is if they keep doing those 3 exercise sessions, they're going to have that exercise preconditioning indefinitely. Say, Barry, show me the data. Here are the data. These are from John Quindry, basically comparing sedentary, unprotected animals, exercise preconditioned animals. He ligates a coronary artery, induces myocardial infarction or severe ischemia, and you can see the profound difference between the exercise preconditioned animals and the sedentary animals in terms of attenuated ventricular arrhythmias, ventricular stunning, and myocardial tissue death. Topic number 4 of the 7, impact of cardiorespiratory fitness on surgical outcomes. Study we did at Beaumont Hospital. Let me set the stage for you. We started doing bariatric surgery in the early 2000s. We had several deaths. The guy in charge came to me one day and said, Barry, we got to better risk stratify these bariatric patients prior to surgery. And I said, Peter, what do you want us to do? And he said, I want you to do stress tests on them and measure VO2 so we can get VO2. And I said, Peter, some of those patients are 500-600 pounds. He's a young cardiologist. I said, how do you do it? How will I do it? He said, you're in charge of the stress tests. You figure it the hell out. Typical young cardiologist. We ended up doing treadmill testing on some, but using a new step, arm leg ergometer, where we put 600, 700, 800-pound people on. In this study, we looked at 109 patients, 75% female, average age 46, average BMI 49, range in BMI 36 to 90. Peter had a hypothesis. He believed the higher the fitness, the less likely cardio complications. I said, I don't think you're right. Peter was right, I was wrong. Basically, what we showed, and for some reason, we're missing a lot of slides, but I'm just gonna keep moving. For what we basically found is less than how many Mets had the highest rate of complications? Anybody know? Take a guess? Less than 5 Mets, 4.8 Mets, yes. It's another study we did, 596 patients who had stress tests at our place 3 months prior to bypass surgery. We were looking to see on the stress test, what was their Mets and how did they do with bypass surgery? It's a paper we published about a decade ago. Titled Effective Cardiorespiratory Fitness on Short-Term Morbidity Mortality After Coronary Artery Bypass Grafting. What did we find? Low preoperative fitness, cardiorespiratory fitness, less, I can't read that.
Less than 5.
Thank you. Less than 5 Mets associated with a higher operative and 30-day mortality after bypass surgery. You say, Barry, show me the data, here are the data. Less than 5 Mets, higher 30-day mortality, higher operative mortality, greater time on the heart-lung ventilation machine. These data were summarized by a brilliant guy in the Netherlands who said, when you talk about exercise, we got to get people exercising, not just after a medical problem, but before. It's called rehabilitation. And his conclusion was people who go into emergent or elective surgery with average to high levels of cardiorespiratory fitness have fewer complications and experience earlier hospital discharge than their low-fit counterpart. Wow. Fitness and healthcare costs. What do we need to know here? Landmark study done by John Myers, Veterans Administration Medical Center. Here they looked at increasing levels of cardiorespiratory fitness, dividing them into quintiles and subsequent annual healthcare costs. Look at that slide and tell me which group had the highest healthcare costs. And as they went from less than 5 Mets to 5 to 6.9, there was a big drop. Big drop. And then as they got more fit, benefits leveled up. More recently, John Myers looked at the Veterans Administration database and found that every Met increase was a $1,600 reduction in annual healthcare costs. I see hospital presidents all the time. They say our healthcare costs are too high. My answer is get your people walking, and you're gonna lower their healthcare costs. Incentivize them one way or another. Next topic, topic number 6, independent additive benefits of cardiorespiratory fitness and prescribed cardioprotective medications. We know that for people with dyslipidemia, if we give them cardiac meds, namely statins, we lower mortality. If they improve their fitness, we lower mortality. In this landmark study, we found that if they on statins and they're also improving their fitness, there's a huge decrease in mortality. It's a landmark study by Peter Kokinis. What happens when you combine cardioprotective drugs plus fitness? And basically what he showed, statin treatment and increased fitness are both independently associated with lower mortality in dyslipidemic individuals. A combination of statin treatment and increased fitness results in substantially lower mortality, almost 5-fold than either alone. reinforcing the notion that if doctors got patients with cholesterol abnormalities, in addition to the darn statin, get them walking, get their fitness up. Say, Barry, show me the data, here are the data. 10,000 individuals, 10-year period, follow compelling data. What did he find? Those who were least fit, no statins, had the highest subsequent death rate. Those who were highly fit, about 11 mets, and statins, the lowest. Almost a 5-fold difference. Topic number 7, 7 of the 7. This is one of the longest topics. Why prescribe exercise? Because we have literally engineered physical activity out of our lives. This is in Japan, but I'm predicting right here this night for the first, you're going to soon start seeing these in the United States and Europe. Contemporary guidelines. We used to say 150 minutes and 75 minutes. More recent data suggests as you go beyond 150 minutes and beyond 7, there's additional benefits. So the World Health Organization in 2020 said these are the guidelines, but the fact of the matter is others have reported health benefits of physical activity volumes far below these thresholds. Don't discourage people by saying I got to do 150 to 300. Look at these data. This was published in Journal of American College of Cardiology. My take-home message on this, and I'll make it simple for you. Number 1, running gives you better reductions in mortality than walking. It's not to say walking is bad, but more vigorous exercise is more cardioprotective, period. Point number 2, just 15 minutes of walking associated with a 10% reduction. Here's 15 minutes of walking. You're getting 10% reduction. That's not the 30 minutes a day we're talking about, and you still get some benefits. The other point is, although running is superior to walking, it requires less time to achieve the reduction in mortality. So what we're saying here is, you can see it right here, 5 minutes of running is equivalent to about how much walking? 15. 25 minutes of running is equivalent to 105. That's not to say everybody's got to run. You can still get a lot of the benefits, but it takes you a little bit longer. Accelerometry, what have we learned? These are the top 8 or 9 publications I recently reviewed. I knew I had about a minute on this slide. So I asked a dear friend and colleague whose name was on all but one of these papers. You may have heard of her, Min Lee, Harvard. And I said, I need a favor. Can you tell, here's 7 papers your name is on, can you give me a sentence or 2 that summarize the take-home message? She wrote, because of the precision of measurement, we now realize the magnitude of association between physical activity and good health is larger than previously known from self-report studies. Because we can measure small, whether by amount, intensity, or duration doses far better than previously, we're beginning to discover that no dose of physical activity is too small to be helpful. Dr. Liz really mentioned this today. We used to say, incorrectly, got to do 10-minute bouts. They kind of pulled that out of the air. The latest study suggests even 1 minute repeated throughout the day gives health benefits. So there's no excuse for anybody. How about walking? For years, when my hair was black, I was telling people 10,000 steps a day. The latest studies suggest, listen carefully, this was beautifully done. Lancet, darn good journal. Daily steps in mortality. They looked at, I think, 15 national cohorts, 47,000 people, 7.1 year follow. What did they find? What she found is under the age of 60, those individuals require some 8,000 to 10,000 steps. The benefits level off right here. For those over the age of 60, 6,000 to 8,000 steps, she concluded, gives you near optimum benefits. The take-home message in this busy slide is this. Listen carefully. If patients are doing nothing, very sedentary, this study and many others have shown that 2,800 to 3,200 steps a day, you begin getting benefits. You begin getting benefits for sedentary people. And now instead of 10,000 steps, I tell people, regardless of age, 7,000 to 8,000 is going to give you very significant benefits. Training intensities to maximize the survival benefits of exercise, 8 sex-adjusted targets. Remember turning a television on several years ago, it said unfit women have shorter life expectancy, details at 11. I normally go to bed at 10 o'clock, but I stay up till 11. See what she does. What does she say is that a study just came out, and I happen to know the author. The study was by Martha Gulati, who's currently at a small hospital called Cedars-Sinai, working in the Barbara Streisand Center there. She looked at 5,700 asymptomatic women, 8-year follow-up. She did treadmill testing on these people. Which group of these women had the highest mortality? Thank you, less than 5 minutes. By the way, that means that those women can't complete stage 1 of the Bruce treadmill protocol. 1.7 miles an hour, 10% grade is 5 minutes. They can't do that. A lot of people said this is interesting. Does this apply to men? John Myers, following year, published these data, Veterans Administration Medical Center, low fitness less than or equal to 5 minutes of the poorest prognosis. So what I'm saying to you is everybody just have to run marathons and start jogging and so on. You say, Barry, give me the biggest bang for your buck, get that patient above 5 minutes, which means they got to be training at 3 minutes or higher. Oh, here's that training recommendation. Let me also add, for some reason the slide didn't show up, but let me also add, they looked at people 60 to 90, and several people said that 5 minutes can't apply to 60 to 90. It did apply. In fact, 60 to 70, 70 to 80, 80 to 90, those who were low fit were 3 to 4 times likely to die prematurely. They concluded the study by saying another good index of prognosis is treadmill test performance. When patients say to me, I want the optimal improvement, we reviewed the FRIEND database, maximizing the cardioprotective benefits with 8 sex-adjusted fitness targets. I had a 64-year-old man not too long ago say, Dr. Franklin, I'm exercising above 3 minutes. I'm exercising at 4. Is that good enough? Is that maximum benefit? From this FRIEND database, we came up with regression equations for exercise training for men and women. 64-year-old man, here's what he's working at 4 minutes down here. My answer was good fitness gives you near optimal survival advantage is about 9 minutes. It's a minute or two of stage 3 of the Bruce treadmill protocol. You really need to get your intensity gradually up to 5.6 to a little above 7. That'll get you doing 9 minutes on a treadmill test at 65 years of age. Take-home messages, these data substantiate the profound favorable impact that regular physical activity, increased fitness have on improving survival, improving surgical outcomes, hospitalization-related outcomes, including acute coronary syndrome, reducing healthcare costs, combating cardiovascular disease, heart failure, cancer, COVID, dementia, stroke, and the inexorable aging process. So you say, Barry, give me the take-home message regarding exercise prescription. It's the magic of get people, your client, above 5 minutes and recognize you can get a lot of benefits just by 1, 2, 3 minute bouts of exercise repeated throughout the day. Take-home message, concluding slide. The increasing integration of regular physical activity and improved cardiorespiratory fitness as medically prescribed interventions, I love this quote, should produce unparalleled synchrony and synergies in favorably modifying health outcomes worldwide. When I looked at that quote, and I'm big on quotes because quotes are the wisdom sound bites of our time. When I looked at that, 2 words stuck out, synchrony and synergies, which reminded me of a figure I recently saw. This figure right here. Synchrony and synergy. In concluding, you may say, Frank, well, you covered a lot of data, but the biggest challenge we have as healthcare professionals is getting people to start and stay with an exercise program. So I will leave you with a quote that I've shared with many patients over many, many years that I think gets the message across. Feel free to steal it. It's by John Ruskin. What you think, or what you know, or what you believe is in the end of little consequence. The only thing of consequence is what you do. Thank you very much, and that concludes my presentation.
Dr. Elizabeth Choi is the Chief Medical Officer for Lore Health. She is board certified in sports and family medicine and received the 2022 ACSM Citation Award for her research in exercise and healthcare. As a practicing physician, she integrated EIM into the Intermountain Healthcare System and has been awarded the Best Doctors in America Award, as well as US News and World Report Top Doctor. She is on the board for the National Physical Activity Plan and has chaired the healthcare sector. She served as the president of ACSM from 2016 to 2017, in addition to being the current chair for the Exercise and Medicine Board.
Well, thanks so much, Kristen, and thanks to everyone who's organized this wonderful day. We kicked off the day having a lovely breakfast, but then meeting with the students, and that's just so incredibly energizing, and it's great to kind of hear what they're doing and the projects that are so incredibly well supported by the diversity of the faculty here. So it's an honor and a pleasure to be here. I've never been to Arkansas before. It was quite beautiful flying in, except for that big fire at the recycling plant. And I've enjoyed wandering around campus today, and it's great to see everyone here tonight. So my presentation will be a little bit different. I'm going to really kind of talk about, I guess the implementation, right? We know that exercise is good for us, right? I mean, does anybody in the room think that exercise is bad? Yeah, I didn't think so. So that was really kind of what got me involved in all of this. As a family physician, knowing that, talking to my patients about physical activity was so incredibly important. How do we introduce physical activity into a very crowded exam room? And by crowded, I don't mean there's a lot of people in the exam room. I mean, sometimes there is, but usually it's me and my patient, but there's a lot of agendas. Turns out, think of your own last visit. You probably had an agenda when you saw your doctor. Turns out your doctor had an agenda too. And so that 18.2 minutes, which is the average face time that somebody has with a primary care provider, a lot of stuff has to happen. And so we needed a way to ensure that physical activity became a part of those conversations. So I'm going to talk a lot about that because that was really the start of exercise as medicine. So how did I get here? That's me in the upper left-hand corner. The little red arrow shows me high-fiving one of my teammates as a volleyball player at the University of Minnesota. And, I've been physically active my entire life. It is absolutely a part of what I am, who I am, what I do. It infuses all of my relationships when I am hiking with my girlfriends in southern Utah. I love this picture of my smiling kids rock climbing in Little Cottonwood Canyon in Utah. That's a picture of me in the upper right-hand corner on my treadmill desk. I'll tell you a little story about that in a minute. I am frequently hiking with a dog or dogs. They are the best hiking partners ever because it makes me a little bit less afraid of the moose and mountain lions. My husband and I are adventure travelers, and this picture was actually taken on a very rainy day at the top of a waterfall in Scotland. But look at those smiles, right? I mean, mind you, I had good Gore-Tex on, but it's the only thing that you need is good equipment. I have to point out that this is my mom. My mom's 87 years old and that's her gym, doing some strength training. She's, has some very severe osteoporosis, has had a number of falls, a number of fractures, and realized that, if she wanted to maintain independent living, she was gonna have to get her ass in the gym. And she found a personal trainer who works with older adults. So I guess, I really do come by it honestly, because that's my mom, well into her 80s. So did I mention she fell and broke her pelvis? Super sad, right? This would be me on crutches when I fell and broke my pelvis. Just this last February, I was skiing, took a really bad fall. And, but I'll tell you, as soon as I figured out how to get down the stairs with my crutches, I was out on the street, walking with my crutches. I'm not sure how many mets I got. I can assure you I wasn't at 5. But look at that smile, right? I mean, I think that's a theme in all these pictures really is look at the smiles, right? Counting smiles, right? It's just so incredibly important. And this picture here is me standing outside of the clinic and looking out of the clinic because, I'm fond of saying that people do not get well and stay well in the doctor's office. They get well and stay well where they live, learn, work, play, and pray. And I know that, I'm gonna make the biggest difference, if I can help motivate people to engage in healthy lifestyle behaviors outside of my office visit, right? Because people spend less than 0.01% of their waking hours with the doctor. Less than 0.01% of waking hours, right? So we have to try and influence people where they live, learn, work, play, and pray. Okay, back to the picture in the upper right-hand corner, because this is a cool story, so I have to tell it. So I was a very early adopter of the walking desk. In fact, I've had one for probably, 17 years, like really early. And the track desk, which you see in that picture, was one of the very first walking desks. And so I was having a regular conversations with the guy who developed them. And with promoting them in some of my talks about workplace wellness. And one day I come to my office at the University of Utah, and in my office is this big gigantic box that says track desk. I'm like, oh my God, this is so cool. And so this guy, Steve, because I've been helping him, with his track desk business, so to speak, he sent me one. And so I pick up the phone, I call him, I'm like, Steve, oh my God, I can't believe you sent me a track desk. And he said, well, you're a really good company. And I said, well, what do you mean? He said, well, I sent out 3. I sent one to you, one to Michelle Obama, and one to Oprah. So, it's the only time in my life I will be mentioned in the same sentence as Michelle Obama and Oprah, but that's okay. So that's my journey to exercise is medicine. And so I hope I present myself as a credible speaker to talk about that this evening. So I'm going to talk about some compelling whys for exercise as medicine. And I just had this feeling that Barry would talk about exercise and heart disease. So I'm going to focus a little bit more on exercise and mental health. And I talk about ACSM's exercise and medicine program, a little bit around its history, resources, and evidence. And before I move to my current role as the Chief Medical Officer for Lower Health, I led health promotion, wellness, and nutrition at Intermountain Healthcare, which is based in Salt Lake City, Utah. And, in that role, I had the honor, pleasure, and opportunity with lots and lots of support from our CEO, who at the time was a 7-time Ironman triathlete. So I'll just have to say, he drank the Kool-Aid. The sugar-free Kool-Aid, mind you, but the Kool-Aid nonetheless. And so very supportive of our work in physical activity assessment promotion, and then finish up with multidisciplinary approaches to address and improve physical activity levels. So I know there's a lot of people in exercise science in the room, but I also knew that there probably would be people who are not. And what are the physical activity guidelines for Americans? And this pertains to adults, that people should be getting both aerobic activity and muscle strength training. And this is ideal. This is where so much of the evidence comes from, that if you're getting 150 minutes of moderate intensity aerobic activity, that is going to significantly reduce premature mortality and incident disease. And then muscle strength training, I think, has been kind of the 4th stepchild here. And yet it becomes increasingly important with aging. really important. And yet, as we've been talking about over the course of the day today, I mean, you know, there's just not that many 60, 70, 80-year-olds who like feel really comfortable doing strength training. They didn't learn it. You know, it wasn't part of, you know, unless they were probably college athletes, you know, and they had a strength coach who taught them how to do that strength training, you know, they're not doing it. And so, you know, when we really look at overall, you know, epidemiology of people meeting guidelines, you know, the reason why, you know, both are so, you know, in combination is less than 30% of people meeting guidelines. Most of the downward numbers are because people aren't meeting the strength training guidelines. They're not engaging in strength training. They don't know how to do it. They don't feel safe doing it. They have low self-efficacy, et cetera. So there's lots of room for improvement there. Okay, some compelling whys for physical activity promotion. So yeah, 75% of US adults don't meet physical activity guidelines. Only 24% of US adults report being advised by a clinician to increase their physical activity. 24%. I mean, that's just horrible. You know, and that's after, you know, more than a decade, you know, of exercise is medicine. So again, so much work to be done in this space. You know, we're up to 40% of US adults who are now considered obese, and, you know, exercise isn't going to solve obesity, but it's certainly part of the energy balance equation. 46% of US adults between 18 and 34 report their mental health as only fair or poor. Really sad. Evidence shows a very strong and consistently positive relationship between regular physical activity and improved mental health. Physical inactivity is associated with higher healthcare costs. Barry shared that, and I'm going to show some of our Intermountain data in regard to that as well. And, you know, just again, thinking of that relationship between, you know, physical activity, mental health, healthcare costs. A mental health diagnosis actually increases the total cost of healthcare by 2 to 3-fold. Right, and increasingly, we're seeing higher rates of anxiety in children and adolescents, and anxiety in young adults and depression as well. So, you know, the health benefits of physical activity, I think, simply put, can be people feel better, they move better, they function better, they sleep better. You know, and that's what people want, right? If I say, you know, if you get, again, you know, no disrespect here, but if you're getting less than 5 minutes fitness, then it's going to increase your cardiovascular mortality by 23%. I'm just making this up. I should have listened more carefully. You know, but what people want is they want to feel better. They want to move better, you know, so that they can play with their grandkids. They want to function better, you know, in their life. I know my mom wants to be able to seamlessly and safely go up and down the stairs because it turns out her laundry is in the basement. You know, it's something we talk about regularly, and she wants to sleep better. And, you know, there are both immediate as well as longer term benefits to regular exercise, and they affect the entire body. You know, every system of the body benefits from regular physical activity. You know, immediately, people are going to sleep better. It's going to reduce their anxiety. It reduces blood pressure, and long term, you know, the impact on brain health, I'll come back to in a second, heart health, cancer prevention. I think we're up to 10 cancers now, you know, that have lower incidence in people who are regularly physically active. We talked about exercise as a component of energy balance. Bone health is super important. I had a paper published within the last year really looking at this concept of musculoskeletal failure. You know, we talk about heart failure, we talk about kidney failure, but has anyone in the room ever heard of musculoskeletal failure? Unless you read my article. But musculoskeletal failure is a consequence of people, you know, largely not engaging in regular physical activity over the course of their lifespan, you know, and learning how to walk, learning, you know, those physical skills, you know, through childhood, maintaining a physically active lifestyle, you know, through adulthood, and then preventing falls and fractures as they in their later years. And then, you know, balance and coordination. Let me go back to brain health for a second, because, you know, we know heart disease is the #1 killer, you know, in the US and globally. But it's interesting, if you actually ask patients, what are they most afraid of? They're afraid of losing their marbles. they're afraid of dementia and cognitive decline, which they feel is out of their control. Like, there's no way to prevent Alzheimer's. They just have to wait until somebody, develops some magic medication, which is going to prevent me from, having cognitive health and not recognizing my spouse. I mean, people are so fearful of that. I totally get it. Totally get it. But you know what? Heart health is brain health. And, and exercise is going to protect your heart. We just heard Dr. Franklin talk about that, an incredible tour de force of the literature. But you could have, in 10 years, we're going to have a similar tour de force when it comes to brain health. Whether it's Alzheimer's, other forms of dementia, Parkinson's disease. I mean, you've got your own expert here too, who is studying this. This is so incredibly important. So I think there is a lot of opportunity for us in age-related cognitive decline, but even at younger ages, just that relationship between regular physical activity, anxiety, depression, and attention deficit disorder. Has anybody read the book Spark by John Rady? Good, I'm so glad to see a few hands. So John Rady is a child psychiatrist at Harvard who has studied the relationship between physical activity and attention deficit disorder because, if you look at the proportion of kids who are being prescribed stimulant medications now compared to say, 15, 20 years ago, I mean, I think the slope of the curve looks something like this. What have we removed from schools? Anybody have any ideas? Recess, right? And regular physical education. I mean, when I went to school, I was in PE every day. I mean, like math, social studies, and now it's, let's see, we have the 3 R's of reading, writing, and arithmetic, and they got rid of the 4th R, recess. Right, and that was a chance for kids to blow off steam and get some physical activity. And it turns out that it helps them learn better. Active kids learn better, and John Rady has done a great job in studying that. If you haven't read his book, I highly recommend it. It's called Spark. I love this. I'm going to show you a couple slides here. So Cure Together was a 5-year study that asked people about various treatments that they were taking for a variety of conditions. So I'm going to show you depression and anxiety. And so they looked at the popularity, the number of people who said that they used that treatment, and then how effective they found that treatment to be. Cure Together is now owned by 23andMe. But in any case, look at all these things. I've prescribed some of these medications like Effexor and Paxil and Wellbutrin. But what is most popular and most effective? And not surprisingly, the same thing is true for anxiety. And so I have actually these printed and laminated, in my clinic. So when people were coming in to see me, with, the symptoms of anxiety and depression, the first thing we would talk about was how physically active were they, right? And, if this might be an opportunity to do more to feel better. Because remember the first thing, it's feel better, function better, right? Because that's the things that people value. All right, so this is a pet peeve of mine, like a big pet peeve. Is when you talk about physical activity, when I'm talking to somebody who's maybe doing very little or nothing at all, the first thing they think about is exercise. And exercise means you gotta go to Lululemon and get some Lycra and go to the gym, right? And that's so intimidating. It's just so intimidating. And then I'll tell you another story. This is why I only needed 26 slides because I knew I would tell so many stories. So I remember seeing this guy in my clinic. I knew him well. We have a physical activity vital sign integrated into electronic health record. And I'm looking at his score, it says 0 minutes on 0 days. And I'm like, oh, that's so weird, because I knew he had a dog. I knew he walked his dog. And so I walk in the exam room and I'm like, John, did your dog die? He said, no, my dog is fine. I said, John, you told my medical assistant that you were getting 0 minutes on 0 days. And he said, well, I'm just walking my dog. It's not like I'm exercising, right? So, That's, yes, more intensity can be associated with better or different outcomes. But, as Barry said, we want people to go, we want everybody to do something, right? And there's this spectrum, all of which are beneficial and all of which counts. So it's activities of daily living, it's active transportation, walking, biking, rolling to work, or to the coffee shop or wherever it is you're going. Lifestyle activities, walking the dog, doing gardening. People who self-identify as a gardener are more likely to meet physical activity recommendations, and gardening is considered a moderate intensity physical activity. And then, of course, there's exercise, which is planned, it's intentional. The purpose is to improve fitness and includes, aerobic activities, strength training, and, whatever other combination of activities you want to do. But it all counts. And I think it's really important that we're promoting that spectrum of activity so that, people can engage the best way it works for them. Okay, I want to talk some now about this, kind of, again, getting more into relationship between physical activity and mental wellness. And we know that we have this epidemic of social isolation and loneliness. And we think it started during the pandemic, but let me tell you, it started way before the pandemic. The pandemic just accelerated it significantly. And again, if you haven't had an opportunity to download this free report from Dr. Vivek Murthy, our Surgeon General, on the epidemic of loneliness and isolation, I really encourage you to do so. It was published in May of last year. And here's just a few snippets from this, this publication that nearly a quarter of US adults report feeling often or always lonely or socially isolated. That, when we think about loneliness, people often think that it's in older adults. It's somebody who's lost a spouse, their friends are dying, they have mobility issues or transportation issues and can't leave their house. But loneliness actually peaks between the ages of 18 to 29. And then, of course, feeling lonely increases the risk of mental health conditions. But, a third of adults between the ages of 50 and 80 report feeling isolated from others. And that number increases with adults over the age of 60. And, another factoid that came from that publication is that, being socially isolated and lonely, in terms of its impact on health, is equivalent to, does anybody know? Smoking a half pack of cigarettes a day. So I think that, in my practice, and my practice was generally, pretty young because I cared for women with, girls and women with eating disorders. But, I've practiced medicine in Salt Lake for 29 years. And your patients age with you. And I definitely, saw amongst my older patients that, again, as their spouses died, as their friends were dying, their kids moved away and didn't live in Salt Lake anymore, they were increasingly isolated. And when we would talk about, physical activity and the importance of that it had on their health, sometimes they would talk about fear. They were afraid, to be physically active. Because they were afraid of falls, for instance. But there were lots of other barriers that I uncovered, right? The more you ask questions, the more you learn and you figure out what those barriers are. But these are some pretty typical ones. And I don't know that, a lot of physicians, take the time to kind of go into this level of granularity when you're talking about giving somebody a physical activity prescription. As simple as, how do I get to the gym? Is exercise safe for me? What do I do at the gym? Again, very little experience. What if I fall? I don't know how to use the equipment. The gym and the gym people are intimidating. What do I wear? And I'm too fat or I'm too out of shape to go to the gym. So it's fear and shame. Fear and shame are huge barriers to people being physically active. And it's not just older adults. It's younger people, and middle-aged adults. And, but I think if we don't acknowledge that fear and shame play a big role in why people aren't active, then we're not really addressing some of those root causes. And it's gonna get, then it's just advice. Information and advice is not enough. So, given that I was really interested in this relationship, I kind of looked to the literature to see if, physical activity was actually a strategy to address loneliness. And this is a systematic review that was published earlier this year. It looked at the relationship between physical activity and loneliness. And what they found was that group exercise, individual consultation and education on physical activity, and social support building during physical activity were promising interventions frequently associated with improvements in both physical activity and loneliness. So, group exercise, again, it's been around for a long time. It shouldn't go away because it actually helps people to kind of have that social connection in addition to the physical activity. I promise I'm not gonna fall. And I think that, it's really important to personalize, a physical activity, recommendation and prescription to the person. If you are regularly physically active, I know that, you struggle a little bit with some, irritable bowel syndrome, and if we can get you moving more, your gut's gonna move better and you're gonna have less bloating and less pain. And oh yeah, you're gonna feel better and function better because that's what people want. Okay, so that's kind of my soapbox. Now I'm going to shift and talk about the Exercise as Medicine program. The vision of Exercise as Medicine is to make physical activity assessment and promotion a standard in clinical care, connecting healthcare with evidence-based physical activity resources for people everywhere and of all abilities. And Exercise as Medicine really was the brainchild of many. It was Bill Roberts, who's again a former ACSM president, who wrote about it when he was editor-in-chief of Physician in Sports Medicine. It was me, writing down, at a Gatorade Sports Science meeting that we need a physical activity vital sign to, systematically assess physical activity in clinical care. And it was Bob Sells who was walking in at that point as president-elect of ACSM to say, I want this to be my presidential initiative. So there was a lot of momentum in that, moving in that direction all at the same time. And it really did allow the Exercise as Medicine program to grow fast. Also had the support of Ron Davis, and Henry Ford from when he was president of the AMA. So lots of forces convened all at the same time to allow Exercise as Medicine to be developed and to continue thriving to this day. And we've talked about the fact that it really does advocate for the inclusion of a physical activity or in the case of Kaiser, an exercise vital sign into the electronic health record and into clinical workflow. Now, I could be super blunt here, but I'd say just, there's a lot of stuff, other words for stuff that start with S, in the electronic health record, which are not very valuable, and have bad product placement and bad clinical workflow. So we've been working really, really hard with the major electronic health record companies, so Epic and Cerner in particular, to try and get really good product placement for the physical activity vital sign. So it will be collected, it will be documented, it will be reviewed, and it will be utilized when it comes to developing a collaborative treatment plan with the patient. So that's how it all started. But now it's been expanded to, the global network in Exercise as Medicine, which, we have 30+ countries and adding new countries every year. As Erin mentioned, there's more than 200 campuses around the world that are part of our Exercise as Medicine on Campus program. Dr. Katie Schmitz, another former ACSM president, she spearheaded Moving Through Cancer, which is a program that's really about integrating physical activity into cancer prehab, cancer rehab, and cancer survivorship. We partnered with the Academy of Nutrition and Dietetics twice now to create the Exercise as Medicine Toolkit for registered dietitians. Because, exercise is a part, as I mentioned, of energy balance. It's really important that our registered dietitians know how to talk to people, not just about what they eat and drink, but also how they move and what kind of activity they're doing. Dr. Mark Stoutenberg, who is one of our program leads in exercises medicine. He leads the Research Learning Collaborative, and I think he was doing it every other month. I think it's now quarterly. And if being a part of that and learning what people are doing around the world in terms of exercises medicine is of interest to you, you can go to the exercisesmedicine.org website and learn how to sign up for the Research Learning Collaborative. And then we also know that this is a multi-stakeholder effort, right? I'm not just talking to doctors, it's not just about exercise scientists or fitness professionals, right? We need to be talking to so many different people about exercises medicine in order for us to be effective. And so we are targeting key ACSM journals, depending on the audience. So we have an exercises medicine section in Current Sports Medicine Reports, which is for clinicians. We have an exercises medicine section in the Health and Fitness Journal, which targets exercise professionals. And then more recently, we just hired, and I use that term loosely because we're actually not paying him, the section editor for exercises medicine in ACSM's translational journal. So again, just trying to, really solicit excellent science to be published in those journals that then can be disseminated to thousands, tens of thousands of people around the globe in order to get our message out. Okay, so stepping back into medicine for a minute, there is an acronym, SBIRT. It's been used a lot in substance use disorders. That's where a lot of the evidence is. But now the SBIRT, framework is used for all sorts of behavior change. And I knew that, as we were creating, implementation of exercises medicine, that we needed to use similar frameworks to what healthcare providers were used to. If all of a sudden I said, we're going to be using the health belief model and social cognitive theory, and they would have looked at me like I've lost my mind. And so we went with SBIRT, screening, brief intervention, and referral to treatment. Now, connecting somebody with an exercise professional is not necessarily treatment, right? So we bastardized it just a tiny little bit here. But screening is, the physical activity vital sign. And the brief intervention, is kind of what I've talked about. It's personalized advice to start, increase, maintain, or modify physical activity. It can include counseling, using evidence-based approaches to counseling, whether that's using the 5 A's or the stage of change or BMAP, or, I frankly think that they all work. I mean, ask Bess Marcus, they all work. It's whatever one you can remember and use consistently, right? And maybe it also includes an exercise or physical activity prescription. Now, I think I tell people we're not rigidly saying that this has to be what happens in the exam room. Because remember, I talked about that crowded exam room at the very top of this presentation. It may be that you have very little time, but just, a 1 minute or less conversation to say, hey, I noticed that you're only getting about 30 minutes of activity a week. Like, what's going on? Wow, well, that's something we should maybe talk about at your next visit. But between now and then, do you think you could maybe try and do, 10 minutes a day? That would more than double your physical activity, get you up to 70 minutes a day. So, that personalized advice is really important. And the amount of time and that's spent in brief intervention, sometimes it's less than we would like. And then on the referral to treatment, for exercises medicine, we describe that as to a person, to a place, or to a program. And, some of those are, I kind of categorize them as either being insurance eligible or insurance maybe. Because definitely, cost is a barrier for a lot of people. And increasingly, there are ways for us to leverage people's healthcare insurance, assuming they have it. And I realize that not everyone does. But, insurance eligible, physical activity resources certainly include cardiac rehab, cardiopulmonary rehab for people who are eligible for that. Physical therapy, because some people need physical therapy before they have physical fitness. Seeing a registered dietitian, and we talk to our dietitians all the time about physical activity. Insurance, maybe, medical fitness, community fitness, seeing an exercise professional, There's actually some new IRS rules that allow us to write letters of medical necessity for people to actually access fitness resources in the community. And then, of course, there's self-directed. And I think the vast majority of people who are meeting the aerobic guidelines for physical activity do so through walking, right? It's a self-directed activity. Within Exercises Medicine, we have the prescription for health theories, and I really do call your attention to this. This is an amazing resource. There's more than 30 medical conditions that affect people, from kids to seniors, and they're available in both English and Spanish. They are regularly updated by both exercise professionals and healthcare providers. They're available free of charge. They can be integrated into electronic health records. I know that it has been in certain settings. And I just included a few of them in that kind of brain health space. But they're really phenomenal. And there are lots of other Exercises Medicine resources for healthcare providers. I didn't include all of the resources for our exercise professionals. But on the left, you see the healthcare providers action guide, which is really what somebody could say. I'm in a small clinic, in rural Arkansas, and I would like to integrate Exercises Medicine. This is their playbook. It's a playbook, and you can do that, and you can work with your administrators to say, all right, let's get started, and we'll use this as our playbook. We've spent a lot of time over the years creating and refining the exercise prescription. And again, available, you can bookmark it, you can print it and have it available in your exam rooms, but it is a wonderful exercise prescription. I've worked for many years around coding and billing because, it turns out physicians are actually on the hook, for coding and billing appropriately. And so helping them to understand how they can do physical activity assessment counseling and still get paid, that's important. And then in support of that, given some, I guess, a reinterpretation, I don't know that it's a new rule, but it's a reinterpretation of a section called 213 in the IRS code, allows us to use letters of medical necessity, which previously I've written for lots of diabetic shoes. That's what I seem to write it for the most. But now I can write it, using the right language for the right indications to connect people to resources, community resources for physical activity. And but most physicians don't actually know you can do that, and most patients don't know. The evidence for Exercises Medicine is deep, and Mark Stoutenberg, my colleague at Exercises Medicine, maintains just an incredible bibliography. Again, it's available on our website. You can look at it categorically if you're interested in Exercises Medicine for older adults, or for fall prevention, or for pregnancy, or whatever it might be. It's an incredible resource. And then there's a number of us. Jerry mentioned Bob Salas, who is my close friend and colleague at Kaiser, who has done work on the exercise vital signs. My colleague Trevor Ball and I have done a lot of validation of the physical activity vital sign at Intermountain. And then we have newer investigators coming on board. Dr. Cindy Lin, who is at the University of Washington, is doing some excellent work. But really focused on what are we doing within healthcare to integrate and implement, physical activity assessment and promotion and referral, and how is it impacting health? So at Intermountain, I already mentioned we integrated this into the electronic health record. We also developed a pediatric physical activity vital sign, which is a little bit different. I'm not going to talk about that today. Like I said, we really worked on good clinical workflow, really utilizing the healthcare team. I mean, healthcare is a great team sport, and the physician can't do it all. We developed referral pathways that were also integrated into the electronic health record. So those are all things that support healthcare providers and team members through tools and workflow. It's really important. If you don't have the right tools and you don't have the right workflow, they're not going to do it. The same way, nobody can build a house if they don't have good tools. Need good tools. And then other things that were kind of a trickle down is the Intermountain's insurance company, Select Health, provides a fitness benefit with some of their commercial plans, and they provide no cost access to fitness programming for Medicare Advantage plan members. Intermountain employees have no cost access to on-site fitness facilities and discounted access to community fitness facilities. And then, you gotta put your money where your mouth is. And so we have broadly implemented Walk with the Doc, where patients can walk with their physician. And these are all activities that support patients and employees by overcoming some cost barriers. And so, I've really tried to be comprehensive in terms of how we integrate and implement exercise as medicine within the healthcare system. But, this is just this is a playbook. This isn't necessarily hard, it's a playbook. You can pick and choose which parts you can do and then find partners, within your department, your university, your healthcare system, to do this. And I wanted to talk a little bit about the relationship between, self-reported physical activity, data collected, secondary data analysis. Our physical activity vital sign was the predicted variable here, and then we're looking at annual healthcare utilization and cost. And I'll just orient you to this slide really quickly. So the light blue boxes are patients who were defined as sufficiently active, getting 150 minutes per week of MBPA or more. The darker blue are people who we define as insufficiently active, and then the gray are the inactive individuals who we define as getting 0 minutes per week of MBPA. This is over 1 million person years and just under 500,000 patients. And again, you look at outpatient visits, inpatient visits, emergency room, total hospital charges, and total hospital costs. And, just comparing, looking at total hospital costs here, there's essentially a 2-to-1 relationship here with the inactive people costing nearly twice compared to the active people. So, as important as I think healthcare is, it's just not enough. And, as I have mentioned repeatedly, that people spend very little time in the doctor's office. Only 14%, this is a study out of Canada just recently, that only 14% of practicing physicians report feeling qualified to offer nutritional advice. And 85% of physicians provided a written prescription for exercise in less than 10% of appointments. I mean, there's just like a lot of room for improvement. And, but, it takes a village and everybody has to row in the same direction. And it's not just up to, a primary care or specialty care provider, but, we need people in mental health, health coaches, pharmacists, dietitians, all kind of rowing in the same direction if we're really going to move the needle. And I think ultimately, we want to help people, who are not active, go from, what should I do? This makes me uncomfortable. I'm too tired, causes pain, it's boring. I think I'm going to panic if I go into 24-hour fitness. With sufficient information, validation, encouragement, motivation, that they can find what works for them, that they feel stronger, that they are energized, that they're having a good pain, that they're having fun, and they're noticing that it's mood advancing. And it's this whole idea, right, that going from something to nothing makes the biggest difference. Going from going from nothing to something makes the biggest difference, right? So that's really what we're trying to do. So I'll conclude my remarks by saying that, the evidence base, for regular physical activity is a key strategy to improve both physical and mental health is incredibly strong. Social isolation and fear contribute to physical inactivity, but we don't talk enough about it. The Exercise as Medicine program is an incredible resource, and please take advantage of what's available. We continually update that information, and it really does help both healthcare providers and exercise professionals. And with that, I'll say, physical activity promotion is a team sport. So let's go team.
All right, clearly it's well of knowledge in the room, but teaser, we have even more. So we're just gonna take a quick 2-minute break, stand up, stretch, maybe walk up and down, get your 1 or 2 minutes of physical activity, and we'll come back to our discussion again. Welcome back. Oh, I'm a student have left, it might be out of their bedtime. No, now we can have a real discussion. So, very excited to introduce the rest of our guests here on stage, if you don't know who they are. So joining Dr. Franklin and Dr. Joy is our third past president of ACSM, Dr. Larry Durstein. He's a distinguished professor emeritus for the Department of Exercise Science at the University of South Carolina, where I did my PhD, so awesome. And his research spans health-related responses, especially involving chronic disease to exercise. And he was president from 2006 to 2007, is that right? Yeah, all right. And obviously these are ACSM rock stars, but we have 2 of our University of Arkansas rock stars here joining them on stage. Way to represent. Dr. Debbie Deere, she's on the end there, is a staff physician at our Student Health Center, so the Pat Walker Health Center here at the University of Arkansas. She's a leader of several campus healthcare initiatives focusing on holistic student health, including serving as the medical director of our UofA eating disorder treatment team. And next to her is Becky Todd. She is the Associate Vice Chancellor for Student Wellbeing at the University of Arkansas Division of Student Affairs. Very important title. I am amazed by the importance of that title. But it oversees university housing, medical services, counseling and psychological services, and university recreation and wellness. So all of those touch points for student health. She was previously the director of programs for UREC, which is our campus recreation department, and a vital part of exercise is medicine. She's also embraced this idea of holistic student well-being and is working on integrating some outcomes from a recent student well-being task force here on our campus. I'd also like to introduce our moderators for our discussion, Madison Sims and Ian Hamilton. They will be facilitating the discussion, and they are actually 2 of our exercise science students, and they also serve as officers for our exercise medicine student group. So we'll give them a round of applause too.
The first question of the discussion is directed to Dr. Durstein. So Dr. Durstein, why do you think EIM is important, and how did EIM get started?
I started it. Well, I do think it's important. I've been involved with chronic diseases for almost 45 years. And yes, I'm only 17. But I actually was asked by ACSM to develop a book with Jeff Moore and Trish Painter on exercise for chronic diseases and disabilities almost 30 years ago. And when the first edition of that book, we saw about 20 health conditions, maybe 25 health conditions or diseases, chronic diseases that were associated with improvement by being physically active. 4th edition or 5th edition, I can't remember, it was a few years ago, and we were looking at that same question, how many, and it was up to 80 to 90 conditions or diseases. So for us, for Jeff Moore and Trish Painter, it's always been this exercise as medicine. We didn't necessarily call it that, so it is, and I think it's one of the most important areas that we deal with. And I'm actually, think about the things I've done, or look at things, I'm really a benchtop guy. I've worked in laboratories doing physiology, testing, exercise testing, and biochemistry, clinical biochemistry. So I think it's very important. I think it's very important. And how did it get started? Liz did a great job of discussing that. But I will tell you, it was 2006, because I was president of ACSM, and Bob Salas, who's a good friend of mine, we had an not editorial board, but the board meeting for ACSM on Saturday, and the leader of that board meeting was so efficient that the meeting was over Saturday afternoon. And Jim Whitehead, who was the CEO at the time, said, well, I like the vice presidents to come back tomorrow morning, Sunday morning, and presidents, and let's just talk about things. And we talked about future things for 2 or 3 hours. And the last hour of that session, Jim said, I'm gonna go around to all the people here. And there's like 6 or 7 of us, and Bill Roberts was one of those persons. He was not he was the past president. And but Bob, our Bill had so much to give to what we did. And I learned so much from him. But Jim Whitehead started us off the vice presidents. And of course, it's the president-elect, Bob Salas, and he said exactly what you said. I want this to be my theme, my presidential year next year. And that was it. That was it. But I was there, like you were there. Thank you.
Thank you, Dr. Gerstein. This next question is aimed at Dr. Joy and Dr. Dieter. In your experience as physicians, what do you see as benefits of exercise medicine for patients and providers in clinical settings?
Well, I'll talk a little bit about benefits for providers, and I'll let you talk about benefits for patients. So for the provider, again, the reason why we make a diagnosis of hypertension is that we have a tool, we have a sphygmomanometer, right, that measures blood pressure. And we have workflow that asks, in most cases, a clinical assistant or a medical assistant to actually measure the blood pressure and document it in the chart before we ever go in the exam room. So we have a tool, that's been around that we trust, it's a valid tool, and we have a process and a workflow. And we have a number, that has decades of research around it that can tell us whether or not the person is normotensive, hypertensive, or urgently, hypertensive and, is at risk. So, we just didn't have anything like that for physical activity. And yet we know how much physical activity people needed to be healthy. And so that required the development of a tool and a process and a workflow and defined roles so that we could actually, collect that data, document it in the electronic health record so it can be scanned quickly. Because I can look at a blood pressure and tell you whether or not it's normal or not in a second. And the same thing is true now with the physical activity vital sign. Somebody who's got 0 minutes on 0 days, man, we're having a conversation. So, I think the development of exercises medicine, the advocacy for the development of physical activity vital signs and integration into electronic health records with really good clinical workflow made, physicians a part of that team, when it came to assessing and promoting physical activity in terms of maintaining health and addressing the role of physical activity in, disease, prevention and management. So I think that that is super important for the providers and their patients. The other thing I would add is that, I can talk to somebody about physical activity, as Barry pointed out in his data, was that you can be, active at any age, active at any size, right? And that, some of Steve Blair's work have demonstrated that people who are, have an obese, by definition, BMI and are fit, have a lower risk of cardiovascular mortality compared to somebody who is normal weight and unfit, right? So that's the classic fit versus fat argument. And so it's, in my patients who had heard from providers over and over and over again, you're tired because you're overweight. You're losing hair because you're overweight. You have depression because you're overweight. I mean, they know that. But a much more positive discussion was to be able to say, hey, Suzanne, let's talk about how much physical activity you're getting. Well, this is kind of what I do. Well, tell me what you like to do. And so having a much more positive conversation around like just energy balance, and doing it from the perspective of physical activity and then talking about all the other benefits that they can get from it. Hey, it's going to help you sleep. It's going to help your mood. And you see people's eyes light up and they get brighter because you know what? You're not talking to them about their weight for the 200th time or the fact that they're doing self-talk about their weight for the 2000th time. So I think it really enhanced that, physician-patient relationship and it reduced shame. And I think it kind of helped people go, okay, yeah, maybe I can do this.
So from the patient side, it is nice to have exercise decoupled from the gym necessarily, and encouraging and meeting people where they are. And we are lucky here on campus to have so many different research opportunities that people can participate in that can help, determine bone density and activity and testing strength and, and doing all the things that EIM does, free, which is such an incredible resource for people who wouldn't be able to get those tests necessarily done, until they meet a certain age criteria. And I'd also like to add that it opens up the discussion, as you were saying, that, when I'm seeing a patient, yes, I do have some patients who feel as though they haven't seen the doctor if they don't get prescription or blood tests done. But so many more are wanting to have conversations about their lives and what's going on and what they're doing and how we can focus on that. Because I will tell my patients, I don't know your weight. I don't look at your weight. We're not talking about that. We're talking about what are you doing and how are you taking care of yourself? What are your behaviors?
Thank you. And a follow-up for that, what are some potential barriers or setbacks to implementing the exercises medicine initiative in clinical settings? And what ways have y'all overcome?
I'll let Dr. Joy discuss some of the overcoming, but some of the barriers, as we mentioned, with time and adding something else for the medical assistant who's screening a patient to do. We've got so many different screenings that we need to discuss, be it substance use, intimate partner violence, safety, anxiety, depression. There's so many things, and then by the time somebody's checked in, half their appointment's over. And so I think time and then implementing it into the EMR are the two largest.
Yeah, adding to that, I would say, the healthcare provider knowledge. People don't like to feel, not competent. And, physicians won't talk about things with their patients, or PAs or nurse practitioners, whoever it is that's delivering care. They're not likely to talk about things that they themselves either aren't doing or don't know very much about. So even when we have the physical activity vital sign data, it might say somebody's getting, 100 minutes a week of moderate intensity activity. And, I bet a lot of physicians are thinking, yeah, that's pretty good. Good enough. I don't need to really talk about that. Because they don't know. And so, informing the people who are providing care about what is necessary from a physical activity perspective, to optimize health. And again, we've talked about the fact that going from nothing to something makes the biggest difference. But, kind of understanding what does that 100 minutes mean? Getting into the weeds a little bit is important. So healthcare provider knowledge is one barrier. And then the other is, that next step, that referral piece. We talk about experts, screening, brief intervention, referral to treatment. And, what does that look like? Referrals out of healthcare into community resources are really tough. Our electronic health records are not well built for that. Community resources don't know how to receive a referral from a healthcare provider. So I've worked on that for years and years and years. It's a little bit easier into an integrated medical fitness facility because it's, within the same system. But when it has to go out into the community, it's a whole lot harder. That's where the ball gets dropped oftentimes. And then, the next barrier is really around cost. And we're definitely figuring out ways to try and lower the cost burden around physical activity. And I think, you have to identify what are all the resources that are available at no charge, small charge, some charge, and then there's gonna be some people who have more resources who might be able to afford more, but you gotta have that discussion with people. And it takes time, so that is another one.
Thank you, Dr. Joy and Dr. Deere. This next question is for Dr. Franklin and Becky Todd. What opportunities do you see for exercise and recreation professionals in the campus setting to incorporate exercise as medicine?
Well, I'm not sure where Dr. Franklin will go with this, so I'm gonna start more from the campus recreation lens. And I could go in a million directions with this answer because I think there's so many ways that it could be incorporated. I think our campus does a lot of collaboration with the academic units, which I think is a great start for the students who are studying the professions that will help carry this into the future. I think another thing that our campus has done really well is to create accessible opportunities to recreation facilities and programs at either no additional cost or very low additional cost. Things like the trail on our campus are great ways for students to have active transportation through campus, to campus, to get sort of, I think, what students would see as passive exercise rather than super intentional exercise. And some other ways I think that we can utilize this is by capitalizing on the data that we already have. So our university recreation department for the last probably close to 10 years has really been trying to dial in and look at usage for students of campus recreation programs and services and compare that to GPAs and retention and graduation rates. And what they see is that first year student retention increases by 15 points or more for users of recreational programs and services versus non-users. And then GPA is optimized for students who are using recreation programs and services 5 to 6 times a week versus students who are using it more or less. There's a tipping point, I think, where the social maybe overcomes the academic study. And I think, students in college are off on their own for the first time. I think, grown-ups, if you will, who have careers and families, live highly structured lives and view college as a pretty unstructured time. But for college students, they have a lot to balance, and learning how to incorporate physical activity into the schedule and into their daily lives at a time where they're learning how to manage all of these things independently for the first time is incredibly helpful habit building that hopefully they can take into the rest of their adulthood, and they have those habits formed and it becomes a really regular part of their routine when they are going into full-time employment or whatever it is they're doing after they finish their academic career, adding, a spouse or a family or children to that dynamic. And if they have this very regular habit, I think it's really good building blocks to set while they're in college.
Let me back off to one point that keeps being made, and I want to put some clarity to it. When we say going from nothing to something, let me give you some numbers, and I've said it here today. When we say going from nothing, you want to be a med capacity, exercise capacity, greater than 5 meds. Okay, greater than 5 meds. Doesn't mean you have to train at 5, 6, 7 meds. You need to train at 3.5 meds. You say, what is that? Once again, 3 miles an hour, 0% grade. Maybe you can't do it day 1, but maybe you can work up to 3 miles an hour. Your patient can work up. Or for older people, say, there's no way in the world I could walk at 2 miles an hour at 0 grade, and then we take them up to 3.5%. Both of those are equivalent to 3.4, 3.5 METs, which means if they're doing that regularly, they're going to beat 5 METs on a stress test. It gets them, to your point, out of the least fit, the least active, the greatest risk people. That's where you say you get your biggest bang for your buck.
Very, very,
Yes.
let me just, I think that's really an important point. Let me add to that, for me, it makes it much clearer. 3 miles an hour is a 20-minute mile.
Yes.
20-minute mile. And for me, that's nothing. But for a person who has chronic disease, that might be a lot, who's only getting 1,000 or 1,500 steps a day. But working up to getting to getting up to 20 minutes a mile would be a fantastic achievement.
And the biggest decrease in mortality.
Yes,
The
yes.
biggest, you go down here and then you get a little bit of addition. So you don't have to run marathons. Also, I failed to mention, a lot of my patients say, I like the outdoor bike. Can you tell me what 3 to 4, but yeah, it's 6 miles an hour. That's not a lot, it's not real fast. It's 6 miles an hour and you're in 3 to 4 METs, which is enable you to get 5 METs. Or how about a stationary bicycle? I saw you got new Monarchs coming in or whatever. The fact of the matter is, stationary bike for the average weight, let's say 140 to 170 or 180, is 300 to 400 kilogram meters per minute. That's the training workload. So now you get everything. Now let me answer this question, and I found a couple ideas. The question is, how do you get more opportunities? I study this stuff for a living. Opportunity, you gotta create opportunities with greater visibility. So what I'm saying is those on campus who are running exercises, you can't get it out there enough. And the best way to do it is not with a small group of 3, but to get the local television or radio stuff. So thousands of people are gonna see a little bit about what is exercise in medicine. And somebody with some money is gonna say, hey, can you use 5,000 out of my endowment or 10? Yeah, we can use it. You create don't wait for the opportunity, you gotta create it. Secondly, partner with others who are better known than you are. There are big physician organizations, there are big insurers who may want to get involved with exercise. Ask, you're gonna get turned down once, twice, 3, and then 4th time, the 5th time, somebody's gonna say, yeah, we'll do that. And it's not gonna cost them anything, they're gonna get some additional visibility. Thirdly, I understand that you got a tremendous enrollment here. Health promotion, exercise science, and so on and so forth. Those students have come to the sobering realization that increased physical activity, increased cardiorespiratory fitness, listen carefully, are going to be increasingly incorporated into the mainstream of contemporary medical care. The data are compelling, increasingly incorporated. We have a new booklet out this week. There's a big warning label on the front of the booklet. It says physical inactivity and low fitness are hazardous to your health. The data here should be apparent. Who's the author of that? The US Surgeon General. So this is not a pipe dream. So recognize that. What I'm saying to you is there's gonna be more and more jobs. Health promotion, wellness, rehabilitation, corporate fitness levels for people with training in this area. And lastly, partner with other organizations. I learned this a long time ago. If you can partner, ACSM can partner with the American Heart Association, who's got access to thousands of members all over the world. You're gonna get a bigger bang for your buck. So there's other associations that I believe will be interested. The American Council on Lifestyle Medicine, American Society for Preventive Cardiology, American Association of Cardiovascular and Pulmonary Rehab. Partner, by partnering with others, you get their memberships, your memberships, and you create synergies that you couldn't do alone. So that's my answer.
Thank you, Dr. Franklin, Dr. Gerstein, and Ms. Todd. This question is for all our panelists tonight. How do you envision the future of exercise as medicine initiative in terms of its public health impact?
I have a point to that one. I thought Liz made a most important point during her presentation, and it might have slipped by you. That point is, what do public schools do away with? Not, they don't do away with it anymore because it's gone. Recess and physical activity or physical fitness classes or PE. The number of PE teachers being turned out each year is lower and lower because there are no jobs for them. And we heard other people up here say, especially you, I heard you say this, that is in college kids, the guys that are going and the gals that are going to physical activity classes or going to the gym do better academically. The same thing is true for kids. There's a group led by Ming Kai Chen, who has a program called Brain Breaks. And what they do in daily classrooms is they introduce 10 minutes of physical activity twice a day. In the classroom, they're walking around, they're dancing, they're singing, they're having a great time. What they're finding is academic performance goes up. So we have done a tremendous travesty in our public schools by doing away with physical education and recess. I know I look forward to my recess when I was a little kid. I look forward to the third recess at lunchtime. I'd rather not eat. I'd rather go out and play. And have you ever watched kids play? They play real hard and they rest. They play real hard and they rest. Play real hard and they rest. What does, Tyrone, what does that sound like? Interval, that's interval training. And if you're a track person, that's very clear what interval training, they already know how to do it. And we discourage it. So when we talk about barriers, coming back to you, because you had some good points. Barriers, we are making those barriers for our kids. And as you were saying, in terms of lifestyle later on in life, we have to be created early. We need to get back to having the kids be more physically active and encouraging it. Thank you.
I think my additions to like the Future of Exercise Medicine initiative, one thing that we know to be true is the highest driver of healthcare costs, particularly like for our faculty staff on our campus, is diabetes. And this is information that I got from our HR, because I was always curious, what's driving our healthcare costs to continue to rise? And on our campus, for our faculty staff, it's a diagnosis of diabetes and the complications that comes along with that. And we know from the research presented today that physical activity decreases those things. And one thing that I wish that our campus insurance did that other campuses do that we don't is provide some insurance rewards for encouraging exercise or participating in exercise, physical activity, however the insurance company wants to implement that. In my role, I have a really huge peek into the struggles of healthcare administration and the convergence of the rising cost of healthcare, the poor state of health for the people that we're treating. And if you can get back down into some of the basics, like what will happen in the future, we'll have a much healthier population who will live longer, our diseases will drop. Like to me, it like all makes perfect sense. Let's invest in the preventative part of it. So for Exercise as Medicine, it's really encouraging to see chapters on college campuses where people who are at the beginning stages of their career participating in this and spreading this message, so that we can maybe have more people who are thinking like game changers to change systems as they go out into their field.
To come back to the referral piece and the collaboration of care, instead of having the physician who may be very ill-equipped to discuss and nutrition, passing along to the dietitian who has those skills. And we do have a dietitian who's offers a free service for students and faculty and staff, and referring on for Exercise as Medicine, where you have the motivational interviewing and the support, so you don't have the physician saying antiquated ideas and or suggestions because they don't have the information for the time or the understanding of getting those in the hands of people who do.
So all really awesome suggestions, and I'll just add another, and it speaks to kind of this convergence, I think, and recognition, based on just a huge expansion of research, showing the value of regular physical activity in terms of both preventing disease and preventing premature mortality. is that we've got the Exercise is Medicine Initiative. We have, the National Physical Activity Plan, which has, been around since the first edition of the Physical Activity Guidelines in 2008. We now have something called the Physical Activity Alliance, which is a large coalition of organizations. Because ultimately, to really impact population health, public health, it's changing environment and policy. Environment and policy are the biggest drivers, of change. And, and there's so many other people that we have worked with at ACSM, Jim Salas and all the work he's done in San Diego, around the built environment and, through active living research is what, he's been driving for, I think, decades. Barb Ainsworth, who's another former ACSM president, who, and Bess Marcus, who have really done so much in, behavior change research. And so I think that, these organizations, EIM and National Physical Activity Plan, and now the Physical Activity Alliance, people are listening. We have people who are working, with the White House, and other policymakers, in a way that, we can actually start to influence environment and policy. And that goes, to schools, right? Right? It's comprehensive PE, right, is about policy, and then holding schools accountable to that policy of comprehensive physical education. So, that's where I think Exercise is Medicine really fits in, is a driver of efforts like that.
I've got a point to add to that, because that's
Yeah.
great. Kim Graber from University of Illinois gave a presentation 7 or 8 years ago in Jakarta, and I happened to be in the audience, and I was actually the next keynote speaker. But in that presentation, she made a point that you just said, in that there are requirements put out by federal agencies saying that every state has to have requirements for physical education. There are requirements. What surprised me is what she said. You know how many states meet those requirements 7 or 8 years ago? 1. Illinois. Not even my home state, South Carolina, or my original home state, Ohio, but didn't match up. And also the District of Columbia met those requirements. I talked with Kim a couple of years ago, and she said, we talked about this issue, and she said, Illinois is not meeting the standards. We're going the wrong way in the public schools.
All right, Dr. Franklin, you got the last word, make it good.
I think the future of exercise as medicine is absolutely enormous. And I'll be so bold as to say, whether Harris wins or Trump wins, listen carefully. Both of their administrations are going to be focused like a laser on getting our healthcare costs down. Because we currently, and we've discussed this earlier today, have the highest healthcare costs in the world, by far. And you say, well, we got the best healthcare system, so our people live longer than the people in Canada. No, they don't. We don't live any longer than the people who in Canada spend a fraction of what we spend. Or our colleagues in Europe who aren't doing 15 angioplasties on a patient and so on and so forth. The future is going to be finding ways that are safe, readily accessible, and highly effective in terms of reducing healthcare costs. And walking and physical activity are right up at the top of the list. They're accessible. You don't have to buy $1,000 shoes. And if we can get people moving, we're going to be immensely successful. And I'll also predict that healthcare insurers are going to increasingly put more responsibility, listen carefully, on the patient himself. Your health, you can't walk around. I see patients all the time that they say to me, I'm not diabetic, we take their sugar, it's 190. How many years they've been walking around with 190 blood sugar? So I'm saying increasingly people got to be more responsible for their health, and they're going to be incentivized with no copays or reduced copays, lower costs, if they make some significant headway in terms of lowering their healthcare costs. Those are my predictions.
Thank you so much.
Thank you, Ian and Maddie, for asking those very wonderful questions. I'm glad Dr. Joy and Dr. Justine brought up recess, because since you're not super familiar with the state of Arkansas, I just want to give us a shout out that we require the most recess of any state in the country. 40 minutes a day. And only 10 states currently require recess, so I think there's a lot to learn, good things from the state of Arkansas. So hopefully you enjoy your visit. Hopefully the rest of you take something home with you from tonight's discussion. There was a lot there. Hopefully you're a little bit inspired, if not for yourself, to go get a little faster walk back to the car, not just because it's dark and because it's cold. But I do welcome you, if you do have some urgent questions, please do come down and talk to our panelists on your way out, because they are awesome. Again, thanks to Dean Kate, to Dr. Green for sponsoring this. We really appreciate it. We've enjoyed their visits. We hope we get to stay in touch, and hopefully they'll see more good things coming from the University of Arkansas. They're gonna have a great night.